So with
Okay,
this
boss.
move, we move to another topic, another very important topic. Half of the job is done by Dr. Khilnani, and the other half, one of the very important aspect of COVID, in the COVID and lung are not separate. So we have a wonderful speaker, a doyen of pulmonology in Rajasthan, no other but Dr. Virendra Singh. He'll be talking about COVID lung. And for that, I have two very senior persons as chairperson moderators. We have Dr. K.C. Agrawal, who is retired principal from Pali Medical College and a professor and head in Jodhpur for a very long time. He is the chairperson, and Dr. A.R. Chaudhary, another very senior physician, as the moderator. Over to you, K.C. Agrawal, sir. Please take over the session.
First of all, I am thankful to Dr. Arun Minal Saab and organizers to give me opportunity to chair this session. And this session is very much important in respect of COVID. And with, in this session, Dr. Virendra Singh with us. He's a renowned chest physician and he's a director of Asthma One Jaipur, president of Rajasthan Hospital Jaipur. He was former head of the Superintendent SMS Hospital Jaipur. He has DCO award and RDC award and Oration award of API and ICS in his credit, and he is achiever of Good Cabinet in India. So I request Dr. Virendra sir to proceed for his lecture. That is COVID and now. Dr. Virendra Singh, please.
Namaskar. At the outset, I am thankful to Anand Minal Sab for giving an opportunity to interact with you all. I am also thankful to Dr. K.C. Agrawal for your kind words. Wonderful lecture was by Dr. G.C. Khilnani Sab. I really enjoyed, and though it was for extra pulmonary, but in pulmonary also it is equally important and that is applied. In my talk, I will be focusing mainly on the COVID lungs and especially on my experience with couple of the cases. Friends, this is pandemic and usually we talk of second or third wave. But if you see the worldometer, in the worldometer you will find that there are 1, 2, 3, 4 and 5. This is almost fifth wave. And as far as number of cases are concerned, the fourth wave was the most powerful wave, and luckily the fifth wave peak is less than the fourth wave. So probably it appears that it is going slightly down. Interesting aspect is that in the first wave, the mortality was quite high, disproportionately high in comparison to other peaks. And one important thing is that in India, we are thinking that probably COVID has gone. But even today, this is today morning data, 46,000 new cases were there. And it does mean 50% of peak of the first wave, still we are having number of these cases. Therefore, we must keep our COVID appropriate behavior in our pattern and lifestyle. That is important. And now I'll be talking about the COVID lungs because we inhale and first home of COVID is nasopharyngeal mucosa, and subsequently it goes and binds to the ACE receptor to injure the lung parenchyma. A patient you can see on the 14th May, there is acute phase of COVID pneumonia, consolidation pattern bilateral. Probably every one of you have witnessed such cases in dozens every day in that particular peak of May and April. This year and September, October, last year, especially in Rajasthan. Though at the moment we are lucky that the Rajasthan number of new cases are minimum in the India. Then this pattern is also present in the lower dose of this patient. And if we compare after fifth day, Then there is increase in consolidation. In consolidation, you can see there is an increase. On the 20th day, again CT scan was done. And the interesting thing is that though there are resolution and there are reticulation, but there is a cavity. You can see, and this cavity was the matter of concern because patient had fever also. Antifungal were started, and with antifungal, fever came down to the normal. And then RHL rehabilitation therapy was continued. She remained on oxygen almost for 1 month, but thereafter she was off oxygen, and with rehabilitation, she was able to walk 300 meters and desaturation was only by 6%. Nintedanib was started in this patient, but it had to be stopped because after 2 weeks time, liver function test deteriorated. That is one of the important factor everyone should keep in mind, that when we start pirfenidone and nintedanib, there should be a regular monitoring of liver function. Dyspnea on exertion is there and irritating cough persists, but it relieved with and with gradual time see there there was 6 base you can see that the size of on day 36 the size of cavity was reduced, but the obliterated mass antifungal. Yeah. Three hundred and and therefore the CTPA and HRCT was done. Interestingly, there was this cavity. Here it is lung window, it is mediastinal window. You know that it is window, it will be dark in the mediastinal window. It is a cavity, it is a mass with cavitatory. Okay. Interestingly, in this patient, a thrombosis was detected. You can see that a right lung, this is the vessel, right lower pulmonary artery is cut off, and it was probably responsible for pulmonary thromboembolic phenomenon, and that was also indicated by elevated D-dimer value. Low molecular weight heparin was given to the patient, dyspnea improved and D-dimer declined, but fever persisted. Now, we could not find the cause of fever, so bronchoscopy was done. And the test for mucor was positive in bronchial aspirate. So it was pulmonary mucor. And amphotericin was given for almost 20 days. And posaconazole 300 milligram is still continued in this patient. You can see that with amphotericin, the cavity got obliterated and replaced mass. Again, on 30th June, after a month, it is missing, and then patient was discharged. Another patient, active COVID pneumonia, patient was admitted somewhere else, but for post-COVID rehabilitation, she was referred to our hospital, and she had bilateral upper lobe with ground glass haziness and consolidation. Organizing pneumonia is also visible here. But the problem on the day 20th, you can see there is good resolution and it is replaced by septal thickening and reticulation. But the problem with the patient was that there was severe atrophy of muscle. She was not able to walk. She was not able to even move her limbs. I still remember I asked her, if you can move your finger. She was not able to do that. What may be the reason? Maybe severe atrophy of muscles and myopathy. As Dr. Khilnani rightly said that in some patients at some places, very high dose of steroid is given. So first thing we did was gradually steroids were tapered and she was enrolled in RHL rehab program. Then second thing which is responsible maybe deconditioning, neuromuscular weakness, excessive lung disease, in many cases heart failure of underlying failure because of occult myocarditis. Enrollment in the rehab program, she was able to walk, and at the time of discharge, she was able to walk 100 meters in 6-minute time. She was really gain. And what was the basic theme of that rehab program? We know that inspiration is an active process, so it needs more energy. Expiration is a passive process, so it needs less energy. So when a person take inspiration, he should not be doing any other work. So Himani used to take breath in and then she used to walk 2 or 3 steps. Then she used to stand again and take 2 inspiration and then is first coupled with this of arrangement. Yet another patient, Lakshmi, you can see that it was irritation she was referred to lesion with background changes of ground glass opacities and septal thickening. Then on day 16, under cavity was found out in the middle lobe, right middle lobe. And after on day 34, you can see that there is a big cavity in X-ray. This is, but on day 73, you can see that there is very good resolution. This patient was again given amphotericin for almost 20 days. This is Mr. Narendra, who again had acute COVID pneumonia and ground glass opacity. So he was admitted with us, and on day 13, he developed severe dyspnea and pneumomediastinum was observed. He could not maintain oxygenation, that's why he was put on the ventilator, and a pigtail catheter was put in the mediastinum, which drained it, and within 6 days, he was off ventilator, and on day 20, you can see that with that catheter, everything resolved, and pneumomediastinum also resolved. He was off ventilator. This was 38-year engineer who got severe COVID with HRCT score so-called 25 by 25. He was admitted somewhere else, but on 12 liter of oxygen, he was referred to us for rehab program. All the things which are contraindicated in rehab program, like active cardiac illness, excessive severe hypertension, any myocarditis, decompensated function, so that is to be excluded. He had irritating cough, So irritating cough, we usually auscultate, and if there are rhonchi, then bronchodilators sometimes provide good relief. Pirfenidone, methylprednisolone, and usually normally COVID patient recovers with time with almost zero fibrosis in 3 to 4 months. But those who are getting complications, they are in the problem. So and antifibrotic patient we are using, but evidence still we don't have much, neither in favor nor against. So it is individual variation. Oxygenation is mainstay of the treatment. Now, how to manage dyspnea? Again, it is individualized thing. We can ask patient to have pulsely breathing. So we did that in this patient also. Diaphragmatic breathing, then coordinate breathing with activity, body positioning, rest before tired, and especially activities like talking, laughing, eating, and coughing. These are quite important trigger because lot of energy is consumed. So there should be ample relaxation and rest. And on the day of discharge, he was quite happy because he was off oxygen, but he drove his vehicle himself to his house. So friends, in the conclusion, I say that there are two things when a patient comes to us in post-COVID pulmonary fibrotic problem. First is exclude diagnosis of any other ailment, exclude clotting, thromboembolic complications, heart failure, infection like fungus and TB, lung puncture like pneumomediastinum, pneumothorax, and then only they should be taken into the rehab program. Rehab program is doing wonderful thing, and you can understand rehab program with this vicious cycle. You can see patient is here, and if this patient is able to walk 100 meter, but on 100 meter he get exertional dyspnea. With exertional dyspnea, he will do less exercise, means he will walk only 80 meter. With walking less than optimal, his body will be deconditioned, and now he will get dyspnea even on walking of 50 meters. So gradually and gradually with the disease, his stamina, physical capacity goes down and down and down, and ultimately he is bound to the cot. Now, rehab moves just opposite of it. And in this, if a patient is able to walk for 20 meters, then from 20 meters, if we ask him to move 30 meter, then next day 50 meter, then 80 meter, he is motivated to walk through dyspnea, though it is difficult, but what. Yes, sorry, there was interruption. Not beyond my. Okay, so with so with he is asked to walk through the dyspnea. Perform well. He is victorious and he can perform his regular activities. Victorious and he can perform his regular activities. Right, and wonderful. I also enjoyed. Met couple of friends. Thank you very much.
Thank you very much, sir, for this wonderful. It
Thank
was a
you.
very important topic. Yes, it was a topic which was in demand so much because everybody wanted to know these details. But your explanation of rehabilitation is unparalleled. we have gone through rehabilitation, but they have never been so simple as you have conveyed. Dr. K.C. Agarwal sir, if there are any questions, Dr. K.C. Agarwal, if there are any questions, so thank you very much.
Thank you. Thank you.
Thank you, sir. Thank you very much.